Every year, over 300 million people undergo surgery globally, and for 10 to 35% of them, pain doesn't end when the stitches heal. Instead, they face persistent post-surgical pain, a condition whose causes remain frustratingly elusive. The pain isn't just about physical injury. It's shaped by the intricate interplay of the nervous system, immune system, and a person's mental and emotional response to pain. This is where machine learning, ML, offers a promising breakthrough. By analyzing patient data collected before surgery, ML algorithms can uncover subtle patterns and risk factors that predict which patients are more likely to experience long-term pain. Past efforts to reduce postoperative pain through clinical trials have often failed, mainly because they targeted isolated risk factors in a highly varied patient population. Persistent post-surgical pain is complex, said Dr. Simon Harutunian, an anesthesiology professor at Washington University School of Medicine in St. Louis. You can't just plug a few numbers into a formula and expect to predict who's at risk. To tackle this complexity, Harutunian teamed up with Dr. Chenyang Liu, a computer science professor and director of WashU's AI for Health Institute. Together with their multidisciplinary team, they created a machine learning model that doesn't just forecast risk, it also tells clinicians how confident it is in those predictions. Their work, published in Proceedings of the ACM on Interactive, Mobile, Wearable and Ubiquitous Technologies, introduces an uncertainty-aware model that avoids the trap of offering black and white answers. As Ziki Su, the lead author and PhD student in Liu's lab, explains, our system can say, "I'm not sure," and quantify that uncertainty. This is critical for doctors. In clinical settings, understanding how certain a prediction is helps doctors balance AI-generated insights with their own expertise. In their study, 780 surgical patients answered daily smartphone surveys in the weeks before their operations. Not all participants completed every survey, so the model also learned to account for missing data when calculating its certainty. By blending this survey data with clinical records such as medical history and lab results, the researchers trained a model that produces both a risk percentage and an associated uncertainty level. For example, patient A, 30% chance of persistent pain, but a 50% uncertainty, prompting the doctor to look deeper. Patient B, 10% risk with 80% certainty, offering stronger confidence in the prediction. Compared to traditional algorithms, their model delivered more accurate and meaningful risk assessments, outperforming others in calibration performance, a measure of how reliable the predictions are, but prediction is only the beginning. The next step is to integrate this model into clinical decision-making, where it can identify not just who is at risk but why. That deeper understanding can inform targeted interventions.